a 42-year-old male presents with acute hip pain and localized tenderness over the anterior groin. I am showing you a frog leg lateral radiograph of the hip. Please describe the findings.
The radiograph demonstrates a cluster of amorphous, ill-defined calcific densities adjacent to the anterior inferior iliac spine, at the anatomical site of the proximal rectus femoris tendon insertion.
What is your primary diagnostic concern?
The findings of amorphous calcific tendon density at the rectus femoris insertion are diagnostic of calcium hydroxyapatite deposition disease, or HADD, also known as calcific tendinitis of the hip.
What specific anatomical tendon, or head of the rectus femoris, is involved based on this location?
This location corresponds to the direct head of the rectus femoris tendon, which inserts directly onto the anterior inferior iliac spine. The indirect head inserts on the superior acetabular ridge.
Which joint is the most common site for HADD in the body, and which specific tendon is most frequently affected?
HADD most commonly affects the shoulder, specifically involving the supraspinatus tendon of the rotator cuff. The hip is the second most common site.
What is the typical radiographic appearance of the calcific deposits in HADD, and how do they progress?
Deposits appear as homogeneous, cloud-like calcifications that are soft and poorly defined during the acute resorptive phase. In the chronic resting phase, they become more discrete and well-defined.
What metabolic and connective tissue disorders can cause similar calcifications around the hip?
Differentials include tumoral calcinosis from chronic renal disease and connective tissue disorders like dermatomyositis or scleroderma. These typically show more extensive, lobulated or sheet-like calcifications.
What benign bone change can occasionally occur adjacent to HADD deposits, and why is it a diagnostic pitfall?
Cortical erosion and bone invasion can occur, which is a key pitfall because it can easily be mistaken for a malignant surface neoplasm or osteomyelitis.
Finally, what are your clinical management recommendations?
I recommend initial conservative treatment with NSAIDs. For severe or refractory pain, an image-guided needle lavage and local corticosteroid injection can be highly effective.